Thank you, Helen, for the kind introduction. In this next session, we aim to share some practical learning from our experience introducing molecular resistance testing for gonorrhoea in a typical large, urban, UK-based sexual health service. We will look at some of the implementation considerations, such as laboratory test nomenclature, human factors issues in clinical electronic systems, and changes to service flow. We will describe some of the health technology systems that have helped us and emphasize the importance of close working between laboratory and clinical colleagues. We have no financial disclosures. Some of the results have been presented at this conference in poster 149. Our clinic, Sandiford Sexual Health, provides specialist sexual health services to a population of around 1 million people living in the Greater Glasgow and Clyde area in the UK. It is served by the West of Scotland Specialist Virology Centre. We've been evaluating molecular resistance testing for gonorrhoea since October 2020. When we approached evaluating the assay from a clinical effectiveness view, we had this primary consideration in mind: what proportion of injectable treatments would be averted. If the aim of molecular resistance testing is to string out our antimicrobial arsenal by using oral ciprofloxacin where suitable, this is an important process outcome. This itself is a function of several factors: efficiency in getting the test results back, sufficient community antibiotic susceptibility, and practitioners being able to assimilate the information and make appropriate antibiotic choices. Traditional culture-based antimicrobial susceptibility takes time. In our own jurisdiction, samples are sent away to a national reference lab, and even though we have direct resulting into our clinical system, we found the results rarely came back in time to make much difference to treatment. When we came to implement resistance testing, we chose to target testing to those samples where the result was likely to make a difference to treatment choice. We're currently running the test as a reflex test twice per week, releasing the standard molecular positive result in real time. So with this approach, the resistance test still follows on from the main lab result, much as in traditional microbiology, but hopefully with a shorter delay. We'll come back to some of the work on result handling later. The second consideration is whether the test would make any difference. We're very lucky in Scotland with a superb specialist STI bacterial reference lab, which in 2019 reported resistance surveillance on about 2,000 cases, around half the known gonorrhoea infections. Here you can see that about just under 70% of infections are ciprofloxacin susceptible, and that this has been stable for some years, and importantly we can continue to monitor this over time. Data for 2020 are yet to be published. We know there have been many changes in antibiotic prescribing due to COVID, and that many public health functions are under pressure. So it's important to check in your jurisdiction what surveillance data you have and look out for rates changing quickly in response to these antimicrobial shifts. While we exploit molecular resistance testing, we have to keep up culture-based surveillance and bank real isolates where possible. The final area is to understand how the information from the test might change practice. There were some key features of our service that definitely helped our thinking here. We do have a very managed system for handling STI tests. These tests are publicly funded and free at the point of need. People with symptoms or presenting as contacts can access tests via our own service, at multiple locations, or from primary care. All the STI testing is centralised at the West of Scotland Specialist Virology Centre. We've got a single electronic record system which services all of our sites, and all the named lab results from any setting, including GPs and hospitals across the West of Scotland, are viewable on a shared records viewer. Importantly, we have a public health agreement to provide oversight and support for positive STI results wherever they are diagnosed in the health board. We have a single agreed treatment protocol in the health board for gonorrhoea, and so we hoped that introducing resistance testing into this mix meant a good chance we would be able to influence prescribing decisions when someone presented. Here's a brief summary of this shared care approach. There may be several reasons why people may be treated for gonorrhea before a resistance test is returned, and these are listed here. We were interested in our work to find out what proportion this may be, as testing someone at this stage has no opportunity to influence their own treatment, though it may conceivably influence treatment a sexual contact might get. In our own jurisdiction, we decided to implement resistance testing of samples we were either uncertain or knew the person had not received antibiotic treatment, and our integrated clinical systems helped with this. This checking does take time to do, and this has to be balanced against the resources saved by running these possibly unnecessary tests. We then worked to choose test names and results that we hoped would be meaningful to clinicians and help them interpret the results. Here's a reminder of our work already presented in the poster. This looks on a patient basis rather than per sample for simplicity. In the first 20 weeks of use, we found that some 40% of patients there was no indication for our testing in the targeted approach, as empirical treatment had already been given. In 3 cases, the resistance test itself was negative, suggesting maybe a false positive initial NAT test. Where we did undertake a resistance test, we found 5 cases where gonorrhea was confirmed, but the GIRA result was itself indeterminate. Looking at this main outcome of injections averted, we found we could manage this in around 18% overall of those with a positive NAT test, and around 31% of those who were eligible for a resistance test. And there were a further 22 individuals who we judged might have been able to have oral treatment, but for one reason or another did not. And here's a breakdown of these main reasons that people with predicted susceptibility to ciprofloxacin were actually treated with injectables. Clearly the commonest factor is that the test was not back in time and a treatment choice had to be made before. There were also some issues about result visibility and actioning this new type of result, with practitioners perhaps preferring to stick to standard treatments. I'd now like to invite my colleague Dr. Elizabeth Moss to present some cases showing where molecular resistance testing did make a difference to management.
Hello, my name is Elizabeth Moss. I'm a junior doctor working within NHS Greater Glasgow and Clyde, and I have been assisting with data collection in this project, working closely with Dr. Winter and the rest of the team at the Sandiford and the West of Scotland Virology Centre to look at how GIRA resistance testing for ciprofloxacin resistance can be integrated and applied into day-to-day clinical practice. I'm going to briefly take you through some interesting cases that will highlight some useful applications of this test. So the first case we will look at is treatment of re-exposure to gonococcal infection and how availability of GIRA resistance testing results allows for tailored treatment in these circumstances. So this female patient presented to the Sandiford for treatment after a high vaginal swab obtained at the general practitioner was culture positive for gonococcal infection. At the time that they presented for treatment, both NAT results and GIRA resistance testing results for gonococcal infection were outstanding, and so this patient was initially treated with intramuscular ceftriaxone. The patient then recontacted the Sandiford a couple of weeks later, where they disclosed that they had had several instances of unprotected sexual intercourse with an untreated long-term male partner. And at this time, we had GIRA results available from the patient's initial presentation, and these predicted ciprofloxacin sensitivity. So the patient was therefore treated with oral ciprofloxacin successfully. So this first case illustrates how availability of resistance results was able to offer a more tailored treatment for re-exposure to gonococcal infection, and this is helpful in reducing exposure to repeated doses of cephalosporins, and it's not an uncommon scenario in our sexual health clinics. So this second case focuses on the delay in availability of site-specific NAT results. So this patient presents for an asymptomatic PrEP screen for gonococcal infection. Initial results show that they have a positive rectal GC with GIRA resistance testing predicting ciprofloxacin sensitivity. Their urine GC NAT is negative, but their pharyngeal GC NAT results are outstanding. So the patient then presents for treatment, and at this time pharyngeal swab results still remain outstanding, and there's concern regarding discordant resistance predictions at different anatomical sites, and for that reason the patient is treated with intramuscular ceftriaxone. So I think this case illustrates the challenge of results from different anatomical sites returning at different times. We've had to take care to make sure staff check results against all anatomical sites before proceeding to use oral treatments. In this case, the pharyngeal gonorrhea result was still awaited, and in the end it did turn out to be indeterminate. So here the clinician reasonably chose to give ceftriaxone. So this final case demonstrates an episode of successful community treatment in a vulnerable patient. So this patient initially presents for an asymptomatic sexual health screen, which was performed by the homeless outreach team. The results return and their vulvovaginal swab for gonococcal infection is NAT positive, and GIRA resistance testing predicts ciprofloxacin sensitivity, and therefore ciprofloxacin was successfully delivered to this patient via the homeless outreach team. So in this last case, we can see the benefit of resistance testing allowing for oral treatment in difficult outreach situations, such as managing infection in a vulnerable homeless population who may find it difficult to attend a central clinic for injectable treatment. During the COVID lockdown, we were also able to deliver some oral treatment to young people who were living at home. Our preference in these circumstances is to see people to try and obtain a swab for culture and sensitivity, although we recognise in some situations like this that may not be possible.
Thanks, Dr. Moss, for those very instructive cases. I hope that you found them helpful. We've shown we can implement resistance-guided testing into a large urban clinical network and avert at least some of the injectable treatments. So we're now looking at two ways to improve our overall effectiveness. The first is that running the test as an extra, coming back after the main result, does mean we'll always have situations where the person presents for treatment before information is available. We also need to think as a specialty about the balance of deferring treatment to choose an appropriate antibiotic with this extra information against the personal and public health need to treat as soon as we can to reduce the risk of onward transmission and to prevent sequelae of infection. Many of those people with gonorrhea were not symptomatic and probably not at immediate risk of transmitting infection. We've also had to educate our staff coming into the specialty more recently about the previous role of ciprofloxacin in treating gonorrhea at all, this new paradigm of resistance-guided treatment, and of course we need to ensure that prescribing of quinolones is safe, contraindications of age and the risks are explained. In this last section, I'd like to touch now on the practicalities of these information systems between the lab and the clinic. This is a new area for many labs, with molecular resistance testing also coming in for Mycoplasma genitalium. It's possible to have dual infection with multiple pathogens and multiple resistance tests, possibly from more than one anatomic site. This can get quite complicated. We chose to call our test in our lab system N-gonoresistance due to limitations in this that only allows 20 characters for a test name and 30 characters for a result. We tried to make results clear by capitalizing the results susceptible. But you can see in this example from our clinic system that a clinician may be cued to think the result means there is resistance present, as the word resistance actually appears twice. We're now exploring some variations in the wording in staff usability panels to try and improve this. Some labs are moving to adopt standard terminology such as that provided by LOINC, and here's an example of representation for chlamydia and gonorrhea testing from this more formal nomenclature. This is new technology, and the terminology of the tests in this more formal system is just evolving. In this example, the test is called a bacterial GIRA gene drug resistance mutation, which is a little too long for our own lab system, but as you can see, this is linked to the MTB panel. Currently, there are no specific entries I can find for molecular tests for gonorrhea or M. genitalium resistance in these LOINC categories linked to panels. I hope this has helped you think through some of the practical considerations if you're considering implementing molecular resistance testing in your own service. I hope we've illustrated the need for close working between laboratory scientists and the clinical services, and for well-governed systems, including antibiotic resistance surveillance, in getting the best out of the opportunities this technology affords. My thanks go to the organisers for inviting us to share this experience, and my many colleagues back in Glasgow who've helped shape this thinking. With that, I'll hand back to Charles Cartwright, Senior Vice President of Clinical Affairs at SpeeDx.